Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the June 2019 edition of PRS Journal Club podcast. I am Lily Mundy, PRS Resident Ambassador from Duke University, and I am joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis, and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. Paul Cederna, the Robert Oneal Professor of Plastic Surgery, Chief of the Section of Plastic Surgery, and Professor in the Department of Biomedical Engineering at the University of Michigan. Thank you so much for joining us, Dr. Cederna, for this PRS Journal Club podcast.
Thanks a lot for having me. I'm really looking forward to the discussion tonight.
The articles that we will discuss can be read for free on PRSJournalClub.com, including an archive of all past Journal Club articles. The first article that we will be discussing is Prosthetic Rehabilitation and Vascularized Composite Allotransplantation Following Upper Limb Loss by senior author Dr. Paul Cederna at the University of Michigan, who we have the pleasure of being joined by tonight. This article is a review and discussion outlining the complex conversation and decisions between prosthetic rehabilitation or vascularized composite allotransplantation, or shortened VCA, following upper limb loss. While highlighting that there is not a superior treatment pathway, the authors discuss the various advantages and disadvantages to each option and outline indications, outcomes, complications, and future directions for both VCA and prostheses. The authors start with a basic overview of prostheses. Options for function include passive, body-powered, and myoelectric technologies. Prostheses are typically indicated for all amputees, with the most common prosthetic type being offered to patients being body-powered devices. Alternatively, VCAs, or vascularized composite allotransplantation, describes the transplantation of typically a portion or distal portion of the upper extremity from a donor to a recipient, which requires immunosuppression. The technical capabilities for VCA have been around for a while. The first technically successful hand transplant was in Ecuador in 1964. However, this failed secondary to insufficient immunosuppression. With the advances in immunosuppression, VCA is now both a technical and a medical option for patients, with the first successful hand transplantation in France in 1998. Since then, there have been around 100 or slightly more successful hand transplants. Next, the authors discuss several discussion points comparing the two options. Regarding patient selection, typically all patients meet criteria for a prosthesis. Alternatively, VCA, similar to all solid organ transplants, requires a rigorous preoperative screening and counseling process. Patients must be capable and willing to undergo the lengthy, rigorous therapy that is required to have a functional outcome, be compliant with an immunosuppressive regimen as well. Level of injury is one of the strongest predictors in outcomes, since this will determine what native extrinsic hand function patients will have and the distance required for nerve reinnervation, predicting the likelihood of success. The majority of VCA patients are wristus articulations or mid-forearm amputations, since some of these patients will retain extrinsic hand function and many will gain intrinsic function. Alternatively, transhumeral patients can expect to have protective sensation and some function that has in previous patients improved a patient's ability to function or perform their ADLs, but these patients will not gain the same level of function that the distal amputations have. In addition, the authors discuss the differences between unilateral and bilateral amputees. Unilateral upper extremity amputees have been shown to be capable of performing 90% of their ADLs, and while unilateral patients that undergo transplantation have still demonstrated functional improvements, this ability to compensate is often referenced when discussing the benefit of VCA for bilateral upper extremity amputees in comparison to the unilateral patients. Post-op, both groups require rehabilitation and therapy. However, the therapy for VCA recipients is often daily treatment for upwards of 2 to 3 years. The commitment to and success of rehabilitation is often the biggest predictor in function for these patients. Functional outcomes comparing the two are limited, since there isn't a consistent standardized measurement tool and there are relatively few VCA patients and even less with long-term outcomes. There are 3 types of outcome measures the authors discuss: patient surveys such as the DASH, clinician-observed outcomes, or kinematric evaluations such as motion analyses or joint angles that are observed during ADLs. In VCA patients, as we've mentioned, the best outcomes were predicted by more distal injuries and a commitment to therapy and immunosuppression compliance. The authors discuss one study that compared 7 VCA patients to 7 amputees with prostheses and with outcomes that found similar functional scores between the groups but improved quality of life outcomes in the VCA patients. However, as the authors of the review note, it's hard to know how to interpret this study since not all patients with prostheses are candidates for VCA. The authors discuss several limitations in prostheses that are reflected in high rates of abandonment and rejection rates, which can be upwards of 60%. These include weight of the prosthesis, limited or lack of sensory feedback, need for visual cues for function of the myoelectric devices, which is in contrast to a body-powered device that has some proprioceptive feedback, and some awkward ergonomics or limited degrees of freedom. Newer devices are addressing some of these limitations with improved ergonomic and functional features, fine motor movements, increasing degrees of freedom, and some sensory feedback information from the vibratory feedback in a user's socket. Several techniques have been developed for more intuitive control of upper extremity prostheses: targeted muscle innervation, regenerative peripheral nerve interface, or RPNI, agonist-antagonist myoneural interfaces. These have led to improved prosthetic control and mitigation of some postoperative pain in these patients. In addition to the improved sensory feedback, research to improve the interface with the prosthetic and the peripheral nerve system is underway. Dermal sensory interface, or DSI, which is comprised of a free dermal graft that's neurotized with a transected end of a sensory nerve fascicle with an electrode on the dermal surface to stimulate the graft to depolarize the nerve and providing sensory feedback, is current research that is ongoing. The current limited sensation of the prostheses are in contrast to VCA, where the majority of patients will develop at least protective sensation, and based on the level of the amputation and time since VCA transfer, as we've talked about, many patients will regain varying levels of sensation. Currently, this ability to regain sensation is a clear advantage of VCA in comparison to prosthesis use. Complications for prostheses use typically include contralateral musculoskeletal injuries secondary to a compensatory body movement as a result of awkward positioning due to limited prosthetic function, as well as rejection of the prosthesis by the patient. Reasons for rejection commonly include pain, poor fit, a late fitting time, weight, proximal amputation level, mechanical failure, limited usefulness, and overall, the cosmetic and functional benefits don't outweigh the discomfort or inconvenience for many patients. Complications for VCA include acute surgical concerns of the technical aspect of the transplantation, including thrombosis, flap loss, wound healing, as well as complications of the immunosuppression, such as opportunistic infections, neoplasia, metabolic disorders, organ failure, and rejection. In a 2015 summary of the available transplants, there were 107 patients who had underwent a hand transplant, with 22% limb loss, or 24 limb losses out of that group, and 4 deaths. The majority of the chronic rejections were secondary to limited access or compliance with immunosuppression, and 3 of the 4 mortalities were in the setting of a combined VCA with a separate body area, such as the face or the leg. Since then, the practice of performing VCAs of 2 separate body areas has widely been considered too risky. So the authors discuss going forward that limitations in prostheses that could improve their impact for patients and their value to patients is the ability to complete complex functions, better intuitive control, not needing to rely on visual cues, and tailored prostheses to serve the needs of the user, as well as tactile and proprioceptive feedback. And many of the newer technologies that are being developed for the interface, such as the TMR, RPNI, AMI, and peripheral nerve interface, are helping to address some of these limitations. For VCA, going forward, things like nerve regeneration, prolonged graft preservation, mitigating the risks of immunosuppression, and allograft preservation while in transport to help with the prolonged transportation time, as well as strategies to minimize maintenance immunosuppressive needs and induce donor-specific tolerance, will all help minimize rejection risks and the impact of chronic immunosuppression. So I know that was sort of a long summary, but with that, I'd like to turn it over to Dr. Cederna, and he was the senior author on the article, and just hear what sort of his thoughts were and goals in writing the article and anything that maybe wasn't included in the text.
Great, thanks for that outstanding summary of the paper. I really appreciate it. It was a good story. Some of the parts of the paper I don't even remember. No, I'm actually kidding. I remember all the parts. I will tell you, writing this paper was a lot of fun. I had the opportunity to spend a lot of time with the VCA folks, talking about pros and cons of the various approaches. And I will say, for the longest time, when we have met at national meetings and international meetings, people always want to say, what's better? What is the approach we're going to use going forward? And frankly, at this stage, my preference is obviously pushing prosthetic rehabilitation forward because that's the area we work in. But I've got to admit that overall, all of our goal is the same, and the goal is to provide patients with functional restoration, which is optimal for them. And so, are there challenges with prosthetic rehabilitation? You bet. Our prosthetics are heavy. They don't have the kinds of degrees of freedom we need. Not all of them provide the capability of doing sensory feedback. And that is all a function of the fact that we've actually never had a good way to interface with the peripheral nervous system to provide good control signals to control these prosthetic devices. And so the most advanced prosthetic devices we have are sort of like Ferraris, And up until this point, we've had no keys to drive that Ferrari, so we haven't actually been able to use it. Now that we have more advanced ways of providing control signals for the prosthetic devices, we actually have an opportunity now to not only provide good signals to control hand open and closing thumb motion, but we actually can provide intrinsic hand control of a prosthetic device and individual finger control. So over the past few years, our peripheral nerve interface approaches have provided more control signals than the prosthetics can actually give us. So not only now do we have keys to our Ferrari, but we actually need a faster car than the Ferrari to control it. So now that we have the ability to provide control signals, the prosthetics can advance. At the same time, on the VCA side of things, there's been an immense amount of work developing new ways to control the response to the allograft so that the patient doesn't reject their transplanted limb. And in this way, as we have an ability to provide better immunologic strategies to reduce the adverse sequelae of global immunosuppression and provide more antigen-specific immunotolerance, we will have increasing opportunities for not only VCA of things like a hand or a face, but ultimately, actually, if we can trick the immune system into accepting allografted tissues, we may ultimately want to do just a nose transplant or just an ear transplant or just a finger transplant. So on the prosthetic side, we're advancing with our control strategies. We're providing more control signals for motor control. We're providing the opportunities to get sensory feedback from the prosthetic devices to give people a sensate prosthetic limb. And on the transplant side, they're providing more immunomodulatory strategies that are selective to ultimately then allow transplanted limbs and other transplanted tissues to have long-term acceptance in the recipient. And so from my standpoint, I love the fact that they're advancing the science forward. I love the fact that we're advancing the science forward. And ultimately, we'll see who is able to provide patients of different varieties with the best functional restoration. And so I'm excited about the work they're doing. I'm excited about the work we're doing. And certainly some patients aren't candidates for both, and so those patients will select themselves out. But for the rest of them, it really is dependent upon how the science advances and where we're going to provide patients with the greatest benefit. Do any of you have any questions about any aspect of that or anything that I can talk about in a little bit more detail?
Yeah, I mean, I think it was really fascinating to read, and we have started to do VCA for upper extremity here at Duke. And, you know, our experience, our interface with the more advanced prostheses is limited. I know a lot of the really high-end interfaces, I mean, you could obviously speak to this more, but it doesn't seem that the civilian patients may have as much access to some of these prostheses as maybe patients do in the military or through sort of research development. I thought it was just really interesting to read the different perspectives.
So you're exactly right. I mean, I think the prosthetic technology is a lot like when I was a kid, when calculators first came out, they cost $1 gazillion and they did nothing, you know, and then as the technology advanced, next thing you know, you buy a bag of groceries, you got a calculator for free. And the price of those things came down. And so now, of course, you get an advanced prosthetic limb. It's really expensive. But as manufacturers make more and more of them, as the technology advances to interface with them to provide the control for them, the prices on them ultimately are going to come down. When you think of some of the more advanced technological devices out there like TAVRs, TAVRs are amazing. That procedure is incredible, and it's just a game changer. A TAVR, it's like $50,000 just for the device itself, but it's worth it. And so, you know, right now in our patients who we have implantable electrodes in, they actually have individual finger control of a prosthetic device. So it's pretty remarkable what they have. And so as we move the science forward and as we move the technology forward, I think it will ultimately become more accessible to the typical patient with limb loss. And at least that's my hope going forward. But even for some of the more advanced technological innovations, they're expensive, but ultimately tend to come down with time.
Raj and Kyle, did you have any thoughts on the article?
Yeah, this is Kyle here. Dr. Cederna, I was wondering what kind of preoperative workup do they have when you're doing more of these prostheses-based kind of things in terms of motivation? If you're doing things like RPNIs or other more invasive procedures, is it similar to, VCA? They talk about, extensive workups. What kind of workup is involved in seeing if patients are appropriate for these prosthetic devices, and which ones do you suggest not try to get prosthetics?
I will tell you that the screening that we do for the patients for prosthetic rehabilitation is pretty extensive, because ultimately we have approval from the FDA to implant up to 12 bipolar electrodes into patients, and they can stay for up to 3 years. And we're going to ask them to come in and have testing on a weekly basis or every other week. And so it's a really big commitment in time and energy. And it's actually a solution for each person who enrolls in the study to not have a permanent solution. Those patients know that they're doing it to advance the science, but they're not doing it personally to give themselves a good prosthetic they can take home. Not yet, but they're really committing to help society by doing this. And so it takes a very particular type of patient, a very generous patient, a very thoughtful patient, a patient with a lot of altruism who's interested in really helping people in the future. And so there's a lot of screening that goes on for our patients for prosthetic rehabilitation. We do regenerative peripheral nerve interfaces on all of our patients. And with that, we're actually able to provide intrinsic hand function and provide sensory feedback for them. But for all of them, none of these are take-home trials yet. They come into a lab, they get hooked up, and then they start controlling the prosthesis. When they're done, they get unhooked, they go home. And so it's a huge commitment for them to do this, but they really are at ground zero. They're at the pointy tip of the spear of this innovative development. And for that, it's exciting for them because they have better control of a prosthetic than anyone has ever had in any prior study. But at the same time, it's only temporary, and it's not something that they can take home to help them play the piano at home or do something like that. And so it's a big commitment, and it takes a lot of screening, but with the right people, you can make a lot of advances. We don't do VCAs at Michigan. I am certainly open to the concept, and with the right patient, it's a very reasonable option, and I do understand the extensive amount of screening they have to do on their end as well, particularly as it relates to compliance with medications.
Yeah, the VCA patients that we've done at Duke primarily have been, well, not primarily, we've only done 2 so far, but it seems that one of the patients that's really benefited was a bilateral upper and lower extremity amputee. So it was really hard for that patient to be able to manipulate, like put her prostheses on without, if she was by herself, and she was always relying on others. So I think for her, that was a big driving factor, which is something that you guys talked about in the article, is the extra utility for VCA in patients that are bilateral.
Sure. And I will tell you that humans are amazing creatures. I mean, even people that don't have bilateral hands, you'll see these people, they can button their shirt, they can put their shoes on, they can do all these things, and you wonder how in the world can they do it? And it's just this drive to be able to take care of themselves and manage all their personal needs themselves without being reliant upon others. It's pretty remarkable. But anything that we can do to make their life easier, it's worth it for sure. It is so worth it. I would just say, as a separate aside, it was a lot of fun going through the editing process because, of course, Dr. Lee and his entire team wanted to talk about the wonders of VCA, and I, of course, and my entire team wanted to talk about the wonders of prosthetic rehabilitation. And so it was nice to have an opportunity to go back and forth and temper all of our claims as much as possible so we were as balanced as we possibly could and have a very fair assessment of each approach.
I think we all really enjoyed the article, and we just feel really lucky that you were able to discuss it with us on the call, since we typically don't have the authors of the articles discussing with us on our podcast. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you liked this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Cederna, for joining us.
Thanks, it's my pleasure.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.